Good morning, everybody. Um, it's this has been a tradition for the past a little more than 25 years. Um, Drew Wilsey was a respiratory therapist. If I don't see anyone in the audience except for maybe one, Sue Miller, who knew Drew Wilsey. Drew Wilsey was a respiratory therapist in our hospital. He was an absolutely outstanding respiratory therapist and outstanding person. And unfortunately, he passed away in 1998 from a brain tumor. And uh, almost simultaneously, myself, Dr. Ornstein, David Ornstein, and Jonathan Finder had the same idea that we need to honor him somehow. He was extremely well loved by the Department of Pediatrics because he was involved in various aspects of respiratory care throughout the hospital. He was also responsible for the current role of respiratory therapy in pediatric transports. And you can see that he's wearing the transport outfit. Um, uh, so we had the same idea to honor him. Initially, it was honoring him by just collecting funds. And then we had the same idea, maybe we should have a named lecture. And Department of Pediatrics, from my perspective, was very gracious to have that as part of the grand rounds. We had a lull when we had COVID. We missed, I think, one or two. But then, thanks to Andrew Buchert, he actually emailed me and said, hey, we need to make this a permanent fixture in the pediatric grand rounds. So today's lecture, Drew Wilsey Memorial Lecture, is to be given by our own Dr. Jane Taylor. I have a list of things. I went through her CV. It's too much to cover within the short amount of time to introduce. It's my pleasure to introduce her. She graduated from UNC Chapel Hill School of Medicine in 2003, finished her residency from Vanderbilt University, 2006, and pulmonology fellowship from WashU in 2009. She has done a master's in clinical research, as well as she has a certificate in medical education from University of Pittsburgh. She's an associate professor in the Division of Pulmonology. Her topic today is Go with the Flow, respiratory care of patients, especially home care of patients with neuromuscular disorder. With for no further ado, please welcome Jane Taylor.
Thank you.
At the end of the talk, I do have an announcement that happens with every Drew Wilsey lecture. I'll do that at the end.
Thank you, Dr. Shaker, for that lovely introduction. And hello, everyone. My name is Jane Taylor, and I am the neuromuscular pulmonologist who works in our MDA clinic every Friday with my fearless leader, Dr. Hoda Abdelhamid. And I have the pleasure of helping these patients live and have an excellent quality of life outside of the hospital and moving around in their communities. And to do that, we have lots of different newer pieces of equipment for airway clearance and for positive airway pressure. And that's something that we are going to go over today so you know what are options for your patients. So going with the flow, home respiratory management for the neuromuscular population. And what I'm excited to tell you is that over the past few decades, the landscape for neuromuscular respiratory care has drastically changed, and for the better. So when I first came out of my training, and according to my children, that was back when the dinosaurs were roaming the earth, we only had one type of ventilator, and the airway clearance equipment was very, very heavy. It was over 40 pounds. So it was very hard for my patients to actually get up and out and move around in the community. And I'm very excited to tell you that in the time I've been out and practicing, this has drastically changed. And we now have much smaller pieces of equipment. They're portable, and it's very easy for my patients to get out and enjoy their lives. So I do not have any financial conflicts of interest. I do sit on some national committees, mostly for medical education and then the large de-identified databases for clinical research. And I am the site co-PI for our PPMD network with Dr. Hoda Abdelhamid. But what are we going to do today? So to understand how this equipment works, we're going to quickly go over Respiratory Physiology 101, so we're all on the same page. We are then going to talk about neuromuscular disorders and how that is impacting the respiratory drive. And then we'll jump into some of the newer home airway equipment for airway clearance. We'll talk through those devices, and we'll talk about some of the new equipment that we have for positive airway pressure support. And this could be BiPAP or home ventilators. So first off, respiratory physiology for our happy lungs. And it starts with the muscles of respiration. So when you take a deep breath in and you're inspiring, the diaphragm, which is the main pump muscle, comes down. At the same time, you have your external intercostals and accessory muscles that are lifting the rib cage up and out. That produces a negative flow and air passively goes into the lungs. You can see that here with what I call the positive arrow sign with the blue arrows that are pointing up and out. Now for expiration, it mainly is the compression of the thoracic cavity through the elastic recoil that now is coming down and pushing that air out. But you also can have the internal intercostals and abdominal muscles that pull inwards and down a little further to get more of the air out on expiration. And again, with the positive arrow signs, those are the red arrows that are pulling down and inwards. So what about normal airway clearance? Because obviously each time you take a breath, you're getting in all the different pollen, all the different chemicals. My kids always ask, what if you inhale a bug, what happens? And the lungs have figured out a way to keep themselves clean. And what you can see here is there are two zones. So the first one is the conducting zone, and these airways are the main large trachea, and then the middle-sized and smaller airways. You have cilia and mucus, which are going to help trap any type of particles that get into the lungs and move them up and out. And you have then the connective tissue. And what I want to point out here is that with that connective tissue, as you go lower down into the lungs to the smaller airways, it gets to be less and less. And those airways get smaller and floppier. And we'll talk about why that's important in the next couple of slides. You finally get down to the alveoli. This is the respiratory zone. This is where you get the oxygen in and the carbon dioxide out. And to keep that clean, if anything gets that low, you have chemical absorption. And then there are cells called alveolar macrophages, which help gobble up any of those particles there. So first off, the cilia, these are little hairs that act like guys on a rowboat, and they have the larger central doublets. And what that does is with the cilia, it helps produce a very fast movement downwards. And this force is large. And if the cilia then stood right back up, it would produce a negative force that cancels it out. And that wouldn't work at all because then the mucus wouldn't go anywhere because it would just be going back and forth. So the cilia obviously is smarter than that. And the central doublets have the cilia that then goes down quickly, and to stand back up, the outer doublets with the dining arms slowly ratchet around with little vector forces to stand back up, which then allows it all to row again straight down. This whip-like motion, when you add all of the vector forces together, so I bet you didn't think you were going to be hearing about physics today, but that gives you a net force that slowly circles up towards the mouth. And that looks like a flushing toilet. So if you've heard pulmonary toilet before, when all of us respiratory therapists and pulmonologists are talking, they're talking about that movement that takes all of the mucus up towards the mouth, and then you can either cough it out or swallow it. And here is another picture that kind of allows you to see that the mucus layer has two different states. There's the solute layer, which is kind of like a saltwater swimming pool, and that's where the cilia are and where they are starting to create this current. The thicker mucus actually floats on top. And this is where I kind of tell my patients it's like fly paper. So if anything comes down and gets stuck on it, that will get moved up and out by the current that's created. Now, what we also know is that it's not just this mucociliary elevator that's important. We also know that the actual breathing and volumes of air that you're moving are important for keeping the lungs clean. The first part of this is the cephalad airflow bias. And what this means is in the lower airways, remember, where we don't have a lot of connective tissue, it's very floppy and they're small. The diameter when you're breathing in and everything is pulling on the airways up and out, the diameter is a little larger. So the flow is actually smoother and a little slower. Immediately when you start to exhale and breathe out, that force presses inwards and the diameter actually is a little smaller. At first you might think, oh, that's terrible. But good old Bernoulli's principle tells us that as we get a slightly smaller diameter in any type of flow for liquids or for air, we see that it speeds up and there's more shear forces on the side. So this helps shear those secretions and move them up towards the middle airway where the mucociliary elevator can then grab it and get it up higher. And then we have our cough, and this is the final phase where after cephalad airflow bias, we're able to get everything up to the larger airways. We have an inspiratory deep inspiration. There's then a compressive force where you have glottic closure and the muscles contract. This builds up negative pressure, and then it opens and you have your expiratory phase, which this gentleman is kindly showing us there, and it gets debris up and out of the airway. So that is a quick review of Respiratory Physiology 101. And how do neuromuscular diseases affect the respiratory drive? What happens when you have different muscles that are weak? So first off, what is a neuromuscular disease? Because this can be confusing. And it is a heterogeneous group of disorders that cause muscle weakness. And it can be anywhere from the anterior horn cells to the axons, to the neuromuscular junction, to the muscle itself. And it's not a central nervous system disorder, but it can have some CNS components, and it's not cerebral palsy, dystonia, spina bifida, or acute flaccid paralysis. But these different conditions also can benefit from a lot of the different airway clearance devices and positive airway pressure devices that we'll talk about to come. And in the MDA clinic, we have over 70 different disorders that are in this umbrella, and it keeps increasing over time. So we see a lot of different patients. This is just a few of the different diagnoses that we see in our MDA clinic. And it's important to know that the neuromuscular diseases, they vary. So one size does not fit all. And even in certain genetic diagnoses, you can have variability there as well. Some are episodic, like congenital myasthenic syndromes. They come and they go. And some are static, so it doesn't change at all. Others progress. And when they progress, some are predictable, like Duchenne's, but others are unpredictable. And it's all about trying to balance the capacity and the load. And what I mean by that is the capacity is how much you can supply of the volume of air for oxygenation. And the demand is how much the body needs or the load that it's putting on the body. And when we have a good strong chest wall, good lung parenchyma, and adequate control of breathing, we're doing fine. Our capacity is larger than the load or the demand. What happens when you have a weak diaphragm or a weak cough, sleep disordered breathing or cardiomyopathy, you actually can have more load than the capacity. And this is where my job is to try and come up with mechanical treatments to then balance out the collapsing and expanding forces and keep appropriate minute ventilation for these patients. So again, let's review. At rest, the red dashed lines, that's your diaphragm, and the purple, that's your chest wall. So this will be the internal intercostals and the accessory muscles. And when you take a deep breath in, the diaphragm goes down, and you'll notice that the chest wall lifts up and out, and there's a lot more volume in that chest. And this is the air that's passively flowing in. When you exhale, the diaphragm goes back up and everything collapses inwards. That moves the air out. Let's talk about spinal muscular atrophy. And this is where the diaphragm is fairly preserved. So it's still doing okay from a strength standpoint, but the accessory muscles are very, very weak. So when I have one of my spinal muscular atrophy patients who is going to try and take a deep breath in, this is what happens. The diaphragm goes down and we no longer have the strength to lift the accessory muscles and chest wall up and out. So they actually collapse inwards. And you can see that there is less space for air to move in here. This is the paradoxical breathing that they talk about in spinal muscular atrophy. When they exhale, the diaphragm goes back up and they actually have more room. So this has also impacts on chest wall development. And the reason that I mention this is because back when we did not have the ability to do positive airway pressure at home, there wasn't much we could do to intervene. And because of the abnormal chest wall dynamics, it was not growing appropriately. And you can see here at 6 months for a patient, we had some significant pectus excavatum. And that's where the breastbone actually is turning inwards. Also, there's something called the bell shape or parasol deformity, which is right along the lines here. I guess you guys can't see it, but if you look at the nipple line to the axillary line, there's really not much space at all. It's like a few millimeters at most. So it's a very, very narrow chest wall. And when you give positive airway pressure over time, that actually allows the chest wall to expand and grow, and also then allows the lungs to grow. So you have better pulmonary health over time. And you can see at 18 months with intervention, this chest wall now has significantly less pectus excavatum. So the indentation here over the breastbone is less. And there's a significant amount of space between the nipple line and the axillary line. So no more bell shape or parasol deformity to this chest wall. And that's why intervening early for these kiddos that have some significant neuromuscular weakness is so important, because it will affect their pulmonary function and lung growth. Also, you'll notice that in our clinics, we position our patients differently depending on what kind of neuromuscular condition they have. And I'm going to talk about SMA and Duchenne's because it's kind of the flip side of the same coin. Spinal muscular atrophy is where the diaphragm is fairly preserved. So that's the muscle that's really working for these patients, but their accessory muscles are extremely weak. So to help them out, you want to make sure you maximize the diaphragmatic movement. And for this, you don't want that diaphragm working against gravity. So these patients, when you have some profound spinal muscular atrophy and they're very, very weak, you have them lay flat. That allows the diaphragm to easily go back and forth, and it's not fighting against gravity. Now you'll notice that in Duchenne's, it's the opposite. And this is because in Duchenne's, the muscles that do the most work are the ones that are damaged first. So their diaphragms are significantly weaker over time than their accessory muscles. So as they start to go into respiratory failure, they're using their accessory muscles much more to breathe. Therefore, you want to kind of help their accessory muscles. You want them more upright in the wheelchair, so the gravity is pulling their stomach contents down and allowing the diaphragm to go lower. And that then allows the accessory muscles also to work a little better. Now, all the different neuromuscular disorders, as we talked about, there's well over 70 that fall under that umbrella of the MDA clinic, kind of fall somewhere on this spectrum. But that's where also, if the patients are like, oh, no, I really need to keep my wheelchair in this particular slant, there's a reason for it. They're not just being picky. So what about airway clearance? And the goals of airway clearance are always to increase the mucociliary function as well as the cough. It improves your respiratory mechanics and it decreases the airway obstruction from the mucus, which improves gas exchange and also helps prevent infection and long-term inflammation. And there are two main strategies that we're going to talk about. The first is the vibratory therapy, and then that's followed by the enhanced cough mechanics or cough assist. And I will say that when used together, we have the best outcomes, but it takes a lot of time. And also sometimes insurance will only cover one piece of equipment. The gold standard, if you had to pick one thing, is the cough assist machine. But I'm going to talk through all the different options. So first off, with the vibratory strategies, we're going to go over the gold standard, which is hand clapping. We'll then talk about the high frequency chest wall oscillatory device, or the vest, as people call it, IPV or Medeneb. And then I'm also going to touch on the handheld oscillatory devices, which are the PEP, Acapella, Flutter, and Aerobica. But this is something we don't use in neuromuscular patients, and I'll talk about why that's the case. So first off, postural drainage and percussion, also known as hand clapping. And this is the gold standard for the vibratory therapy. And they've done a lot of studies on this. And in trained providers or respiratory therapists' hands, it works just as well as the vest. And this is why a lot of insurance companies want you to do hand clapping first before they would consider moving on to a vest over time. And you basically are going to use the vibratory clapping with gravity enhanced secretion positioning and drainage. This is what we use in all of our cystic fibrosis and primary ciliary dyskinesia children when they're very young. These are the different positions that we put the patients in. And you'll notice that you can use hand clappers. So there are 4 of them up there, different sizes for whatever size patient you are going to use this on. And believe it or not, you can get this at Walmart for $10. These are very cheap. And again, if family members have the time and they're trained and consistent, very good therapy. Now, there are, over time, for my neuromuscular patients, they can develop scoliosis, so it's harder to get them in these positions. They also start to grow, so they weigh a lot more. It's harder for their parents, who also are aging, to move them, and they start to get bone density issues. So at these times, if that develops, that's when I can start asking the insurance company to think about a vest. And I will also point out, it's not covered by insurance, but it's not too expensive. So I have several families that have gone out and bought that black device down there. It's a handheld device that's a percussor, and it only costs about $100 to $200. So a lot of families have gotten that as well, and that works. So moving on to the high frequency chest wall oscillatory device. And this is what we call the vest, but that's actually just one of many different pieces of equipment that do this. And the main kind of expensive part of these systems are the compressors. And those are the devices that you see the actual vest garment and tubing is plugged into. And that sets up the vibrations that shears the mucus and allows them to cough it up and out. And what I will tell you is, of course, for things like cystic fibrosis or primary ciliary dyskinesia, where they have a buildup of mucus everywhere, you want to use the actual full vest garment that covers the apices of the lungs and all the way down. Now, for neuromuscular patients where they don't have this really thick secretions that are retained, you don't necessarily need that. And moving them, because they have scoliosis, bone density issues, and other problems, can be very hard to get them into the vest. So if we do use this, we actually use that wrap, which is right up there, that just goes around the chest wall. Now, in the hospital, we used to be able to get this for some patients in the home, but over time, they stopped making these machines, so there's not as many out there now. So it's mostly just in the hospital, is the IPV, or intrapulmonary percussive ventilation. And a similar device, Medeneb, is what we use here. So you residents probably are aware of what Medeneb is. And what that does is it vibrates, so it gives you those shear forces to help loosen the mucus, but also at the same time, it's pushing air in. So it is helping to prevent atelectasis. And we use this a lot for the neuromuscular patients who have undergone like spine surgery or sedated procedures with the IPV. So we shake everything loose, we re-expand, so the atelectatic areas open back up, and then do the cough assist right afterwards. So that's a common combination that you'll see here in the hospital when you're on the wards. Now, I also promised that I would talk about some of the handheld devices, which are excellent devices when used for the right type of patient. But hopefully I will convince you that the neuromuscular population is probably not the best group to use these in. And these are called the PEP Acapella Arabica or flutter devices. Those are the ones that are used in Pittsburgh. And patients ask me, well, which one is the best one, Dr. Taylor? And I tell them these are very similar. The best one is the one that your insurance company is going to cover and the one that you use consistently. So what you do is you have to ask the patients, so this is where they do have to be old enough to understand instructions to take a huge deep breath in, and then you have them seal around the mouthpiece and blow as hard as they can. That actually will then set up a standing wave. So when you have that expiratory force or cephalad airflow bias, but in neuromuscular patients, it can actually flop a little too low and collapse the airways at the top. If you set up the standing wave down in B at the bottom, that actually will help keep some of the pressure from collapsing down too far and the airways remain open. So this is where it would be excellent, and a lot of cystic fibrosis patients, because it's faster than a vest, use it intermittently with the vest throughout the day, especially when they're at school to help with airway clearance. But in patients where they can't take deep enough breaths or generate a forceful flow, like my neuromuscular patients, it's just not going to work. So not the best option for them. And people also ask about how much do they cost out of pocket? Around $60 to $80. And these are covered by insurance for the appropriate patient populations. And again, do not use them for my neuromuscular population. So to sum it up, we use a lot of manual chest physiotherapy. When the kids get older, they get scoliosis and bone density issues. That's when I'm usually able to ask for the high frequency chest wall oscillatory device. We have the IPV and MetaNeb machines for the hospital right now, but there is a European company that is working on getting FDA approval. So we might have some devices for the home in the future. And very worst case scenario, hospital only. If truly mucus is getting stuck down there and it's plugged, we could consider a bronchoscopy. But remember, guys, in the neuromuscular population, we would have to have them intubated and might not be able to extubate. So that is truly last resort. Medications that you might see me order for my neuromuscular patients, albuterol. It helps dilate the airways, but also it triples the ciliary beat frequency. So all of my patients say, you think I have asthma? And I say, no, I don't think you have asthma. But if you get really, really sick and there's a lot of mucus down there and you're having a hard time getting it up and out, using the albuterol right before you do the cough assist can be very helpful. We also will use Pulmozyme mostly in the hospital if there is a severe infection. 3% hypertonic saline to thin out secretions when they're in the hospital if needed. And some patients benefit from Mucomist. We try to avoid drying agents. So Robenal, scopolamine, not my favorite. It does help decrease the secretions here, but it can thicken it down in the lungs and make it harder for me to get it up and out. But in kiddos that have things like RSV or really bad viruses and they're just pouring copious amounts of mucus out, you absolutely can use them. Just make sure that you then wean them off as they start to get better. And asthma medications in select cases. This always has to be followed by the cough assist. And the cough assist, also known as mechanical insufflation, exsufflation devices, enhance the cephalad airflow bias, and they also enhance the cough forces. When do you start using this? Well, when peak cough flow is less than 270 liters per minute for an adult, or maximal expiratory pressure less than 60, or in my very young children where they cannot do any of those testing, if they have recurrent respiratory infections, abnormal chest wall shape, I also can get that approved. And what do these devices now look like? Because back when I was in training, so when the dinosaurs roamed the earth, it was over 45 pounds and these things did not go anywhere. They were at home and could not move. Now we have portable devices that weigh less than 20 pounds and families pack them up, stick them in the car. They go to the baseball fields watching, siblings play. They'll go to church, they'll go to school. And there are three main types that you're going to come across here in Pittsburgh. We have the Hillrom Sinclair cough system. We have the ABM Byways cough system and the Philips T70 Respironics cough assist. I will tell you that Philips is starting to back out of the respiratory care market. So the Philips Respironics T70 cough assist are around, but they're not making new ones. So over time, these are going to be phased out. And these can be used with a mouthpiece, a face mask, or a trach. And what does it do? Well, you can see here with the green, those are just regular pre-treatment breaths. When you actually put on the pressures, that doubles the flow. And you have that cycle in and out, and at the end, suction. I always tell families also end with an inspiratory breath. So that's the red on the end, because you want to make sure that you re-inflate after you've pulled. And what kind of settings? There's lots of different settings here. The take-home point is it's done in the MDA clinic with me, or I have the respiratory therapists from the durable medical equipment company go out and take a look. And we're looking at the chest wall rise. We're looking at how much mucus is coming out, how much suctioning, and if the kids can tell us how they're feeling after therapy to come up with the actual modes. You can do manual, but these are mostly in adults that can give us feedback. For kids, it's more of the automatic. So we set actual cycles. And what's very exciting is recently, all three machines can do something called oscillatory settings. So what this does is while it's pushing the pressure in, before oscillatory settings, it was just a straight flow, like that. Now you actually can adjust amplitude and frequency, and it gives you some vibrations. So it goes. It hasn't been around long enough to really do the studies comparing kind of vest hand clapping, cough assist to this oscillatory settings, but the patients that can communicate with me tell me that it seems to work just as well and it takes up a lot less time. So they have actually given back the vest and aren't doing the hand clapping as much and really just using the oscillatory settings. So this has been a game changer, and all three of the current cough assist machines at home can do this in the Pittsburgh area. Now, what's also exciting is they have come up on the Sinclair and Byways giving a PEEP pressure during the exhalation where it's pulling it out and the pause time, which helps keep these upper airways open and doesn't allow them to fish mouth down with that pressure pull for the neuromuscular patients. And that also helps prevent some mucus plugging and remove more mucoid secretions. So that also is something that we now are able to do in the home setting. And it's only been around for about a year, but patients have really reported significant more mucus coming up. So again, we do about 3 to 5 coughs per cycle, 3 to 5 cycles per session. When you're well, I tell patients to use it 1 to 2 times a day. When sick, 4+. But if they're consistently needing it more than 4 times a day, to give me a call, because then I worry about pneumonia or bronchitis, something like that. And they suction between the cycles and at the end. And I tell them try and avoid deep suctioning so you can scar the back of the throat, but also trigger vomiting. And we want to avoid that. And then watch for oxygen desaturations closely. But if these start happening, don't stop. It means that mucus is there to be moved and we want to get it up and out. So here's an example of a script for cough assist, because a lot of times my fellows are like, well, how would I write for this, Dr. Taylor? And you can see here that we do the pressures, both insufflation, exsufflation, how many cycles of what, and I do 5 cycles of 5, ending on that inspiratory breath. That's really important, guys, that you put that. And then the time frame for the insufflation, the exsufflation, and the pause. I often will tell them to trial oscillatory settings, and you have to tell them to adjust the amplitude and frequency per patient preference. And then I set that EPAP for the pause and exsufflation times. And this is just a very involved table that goes over all of the starting approaches for cough assist parameters. I'm not going to go through all of it, but I want you guys to see that it's here, because you can look back at my slides later if you're interested. And also there's the citation for the ATS book chapter that recently quite a few of us neuromuscular pulmonologists worked on together. So it can give you some of the most up-to-date information on how we start to titrate for the pediatric neuromuscular patients. Okay, so let's move into positive airway pressure. And everyone says it gets so confusing. You have your IPAP, your EPAP, your BiPAP, your CPAP, and it's all positive airway pressure. So when do we start this? And subjectively, if there's any signs of sleep disordered breathing or sleep quality issues, also recurrent pneumonias or persistent coughing, we would start it if there's poor growth, abnormal chest wall development, and definitely recurrent hospitalizations allows us to consider starting it. Objectively, for patients that can do pulmonary function tests, it's if the forced vital capacity is less than 50% or maximal inspiratory pressure less than 60. If you show signs of alveolar hypoventilation during the day, your oxygen's less than 95 and your CO2 over 45, definitely that's another indication where we can start it. And also if you have a sleep study showing abnormalities, that is the easiest way to get this obtained. Now, families often ask CPAP versus BiPAP. Remember, CPAP here is the continuous low pressure, and that's really just there to keep those upper airways open. It doesn't give you enough pressure to move larger volumes of air that gets more oxygen in and carbon dioxide out. So it's not going to help you with minute ventilation. Now, down below, that is our BiPAP, and that means bi or two types of pressure. As soon as you are taking a breath in, you can see that the pressure goes higher, and this is going to allow more air to flow in and improve your minute ventilation. And this is what you want to use for patients that have neuromuscular weakness. I remind everybody that oxygen without pressure does not help and can only hurt you. So we do not put on oxygen without monitoring very, very closely. And it makes me very nervous, guys, when this happens, because you can start to retain CO2 slowly, and patients have on the oxygen gone apneic before. So what I try and tell all of my trainees is if you are going to use oxygen, because sometimes we do need to do that for kids that have bad pneumonia, make sure they're on positive airway pressure and that you've set a rate. So no CPAP, no just straight oxygen. The way to go is with BiPAP. And then if they still need a little bit of oxygen, bleed it through the BiPAP. And that can be either a BiPAP machine or a home ventilator. We also talk about the need for the wide pressure range, so at least 10. And what that does is allows us to have a larger exhaled tidal volume. This is the high span strategy that you'll hear neuromuscular pulmonologists talk about. So we really want to make sure that as we support these patients, we're giving them the most volume of air that we can comfortably and letting them rest their muscles. So goals during sleep is to completely support them. So you want to make sure that the rate is capturing what they're actually doing. They're synchronizing with the machine and you're getting good chest wall expansion. You're using your high span BiPAP strategies. So if I set like the CPAP at 6, we would then set the IPAP at 16 or higher. And you always want to make sure that you have a backup rate. And people are like, well, sometimes, they're triggering it on their own. And that's true. When they're well, they can trigger it on their own. But when you get sick, you can get significantly weaker and you might not be able to generate those flows to trigger the machine. So you have to have that rate on for safety. It'll kick in if they get very weak. Again, suggested approaches for how to start setting up non-invasive settings if you had to do so on the floor with a patient. I'm not going to go through all of this, but it's there in the slide set. You can look back, or on PubMed, you can look for the article itself. What are some of the key differences between BiPAP and home ventilator? And this comes up a lot when we are talking about sending patients home. And it's important to understand that on BiPAP machines, they are very slow to adjust. They do not adjust on a breath by breath basis. The home ventilators can. They are very, very quick to adjust if needed. Now on the home BiPAP machines, because they're pretty slow and they don't have the same algorithms for sensing flow, you have to be over 30 kilograms to use a home BiPAP machine. For the home ventilators, we have the Trilogy Evo that is down to 2.5 kilograms. Again, Philips Respironics is pulling out of the home care market. So that's only going to be available until 2029. The other ventilators, they are all approved for 5 kilograms on up, and some are starting to work on trying to get approval for kids down to 2.5, but that has not happened yet. The BiPAP machines do not have a lot of alarms, whereas the home ventilators do. And this is the big one. BiPAP machines do not have internal batteries. So if the power goes out in the middle of the night and you truly have an individual who's dependent on this, there is not any way to ventilate them. The home ventilators have an internal battery that will kick on immediately in case there's a power outage and support them for 8 hours. And there's also external batteries that we have for the families that they can then plug in as well. So usually they have up to about anywhere from 10 to 15 hours of battery life in case of an emergency. The FDA has approved the BiPAP for non-invasive only. You cannot hook this up to a trach. Home ventilators, you can use it non-invasively, or you can use it invasively with a trach. What are the different types of machines that we currently are using in Pittsburgh? What will you see? And the 4 most common currently being used are the Brius Vivo, the React Health Luna, ResMed AirCurve, and then the Philips DreamStation. Again, Philips is going to be going away, but as you can see with all 4, they are very, very small. They're portable, they're easy to plug in, and you can even travel on planes with them. So not very heavy at all. The home ventilators are a little bigger, but they also do a lot more. And even with the biggest one, they're less than 20 pounds and they are portable. So we have the Ventec Voxen V Home and now a V Plus Pro. We have the ResMed Astral, the Brius Vivo, the Mover Louisa, and then the Philips Respironics Trilogy Evo, which they're not making more of, but they are making replacement parts until 2029. But that will be phased out eventually. So let's talk through some of these because everyone also asks me which is the best ventilator. And I tell them, actually, one size does not fit all. The ventilators all do things a little differently. They're all good machines, and it's really knowing the family and what their goals are to pick the best ventilator for them. So the Trilogy Evo, obviously for our NICU patients, we like this ventilator, and it has very good flow algorithms for young children, and it can quickly adjust. So we do have most of our NICU kids right now on the Trilogy Evos. It is light. It has excellent combined battery life of up to 15 hours. You can use it non-invasive or invasive, and it has all the bells and whistles for the different types of settings. So it is a good machine. We also have the Ventec series, and I do have patients that are on this and choose this ventilator, and it is a little heavier. The battery life is a little more variable because it actually is not just a ventilator. It also has an oxygen concentrator. It has cough assist. It has suction and a nebulizer all in that one machine. So if you are a middle school or high school student who is needing to lug all of this equipment to class and you have a nurse that goes with you, it can be really hard to move quickly if you have 4 or 5 different pieces of equipment. Believe it or not, I've actually had 1 or 2 patients that haven't been able to go into certain rooms in their school because their wheelchair and the different equipment hanging off of it was just too big. They would get stuck. So this is a very nice ventilator if you're trying to make sure that it is in a size that they can easily move it around in a school setting. Now, because Philips Respironics is going out of the respiratory care field, the Ventec group realized that they are going to need to try and help and produce more home ventilators. And not everyone needs the Voxen. Sometimes you just need a good home ventilator. So they have started to produce the V Home and the V Plus Pro. It looks exactly the same as the Voxen, and this is why I mention it, because we have ordered Voxen and families have gotten the V Home or V Plus Pro and have been a little disappointed because it doesn't have any of the other bells and whistles. It doesn't have the nebulizer, cough assist, or suction. So just be aware that Ventec now has 3 different vents that are out there for our families in Pittsburgh. The ResMed Astral is a lot like the Trilogy series, and a lot of my friends that are in the West and West Coast actually use the Astral series predominantly, and also Canada. So there've been a lot of kind of data and use on this ventilator. It is very similar to the Trilogy series. It does not weigh very much. It has excellent battery life, and it's a good ventilator. Patients like it. Now, the dinosaur of the home ventilators is the LTV. It is definitely heavier. It's been around the longest. Battery life, not quite as good, but this thing does not break down, and that's why it is still out there. This is the ventilator that I was prescribing when I first got out of fellowship training about 20 years ago. So this is still working well. And they have seen that there is a need now for more ventilators and are going to roll out an LTV2. So that should be coming in the next year or two. And I've been told that the battery life will be longer and it's going to be a little smaller. But they're also an excellent company with a wonderful track record. Now, Brius Vivo, I have not had many patients on this because it doesn't have as much internal battery life on it, but it's incredibly small. So when I visit the different advocacy groups nationally, and we have some of our young adults who actually are employed and have jobs and lives, and some with families and need to really move quickly and get everything up and out, this is an incredible ventilator. They're like, we're never going to be away from, an actual plug. So this is the one that we can easily like put in a walker or under a chair and just move. So a lot of older adolescents and adults, especially those that have jobs, like this ventilator. Now, the Mover Luisa, this is one that is undergoing FDA approval for adults, and also they have expedited approval for children now that we know that the Trilogy Evo is going to be phased out in the next several years. This device does not weigh that much. It has high flow capabilities, which is very exciting. And the adults have also been trialing it at the UPMC adult MDA and sleep centers. And they report that the way the screen is, it's able to give you feedback on changes in almost a minute to minute basis, instead of some of the downloads that we get that's more on an hourly or daily basis. So they're able to titrate a lot easier in clinic with this ventilator. And that's a nice feature. Again, there's lots of information out there about the ventilators. Recently, a group of us tried to combine all the information that we had found. So you can go back and take a look at some of these tables if you have interest later. It goes over all of the different internal and external battery lives, what the weight is, patient requirements, and different modes that it supports. It goes through the ones that are currently being used here in North America. The ventilator dimensions, because this can be very important if you are trying to fit different adaptive shelving on the wheelchairs. So here are all the dimensions of the different ventilators and types of interface for non-invasive if you're interested. But I know this was a lot of information and I'm sure there are questions. So thank you for listening, guys.